Good afternoon, everyone. Thank you for joining today's symposium. My name is Anana Oyabo, and I'm a program manager in the Center for Health Information Technology and Innovative Care Delivery at the Maryland Healthcare Commission. MHCC is an independent regulatory agency. One MHCC priority is to advance innovative value-based care delivery. This includes supporting innovations that focus on improving health equity, outcomes, and quality of care. This slide outlines important information about CME credits and disclosures. Following the event, you will receive an email that includes a link to a questionnaire. The questionnaire requests feedback on the symposium and an application for CME credit. We would appreciate your feedback even if you're not applying for CME credit. Our speakers today have no disclosures to report. During today's symposium, you will hear about statewide health equity initiatives and strategies to address health equity challenges, identify social resources for patients and patterns of need. Princess Collins from the Health Services Cost Review Commission and Jean Ransom will share information on some statewide initiatives. Dr. Patricia Zapp, along with 4 panelists, Dr. Conway, Basinski, Sputz, and Ms. Newsom, will discuss real-life examples of how individuals are impacted by adverse social determinants of health and identify relatable strategies that empower patients and families. Before we get started, I would like to cover a few operational items. The symposium is being recorded and will be posted to MHCC's website. We have a large number of attendees today, so we thank you in advance for keeping your camera turned off and your line muted when you're not speaking. There will be opportunities to comment and ask questions during the question and answer session of the event. You may enter your comment or question in the chat box at the bottom of your screen. I will read these out loud to the presenters at the time of the question and answer session. You can also raise your hand and I will call on you when it is your turn to ask a question. If you have any issues with Zoom, please contact one of my colleagues, Anna Gripple or Justin Springer, for assistance. Their contact information is included in the event materials emailed to you on Thursday. At this time, I would like to ask our executive director if he's available. Melanie, is he available at this time to start us off with a few opening remarks?
I don't see him. David, would you like to make some opening remarks?
Sure. Good afternoon, everyone. And thank you all for attending, and thank you to the panel presenters and to the MHCC staff and to our colleagues and friends at the Medical Society for taking part in this very important event today. Our executive director, Mr. Ben Steffen, was hopeful that he could join us remotely, but was called to Annapolis to participate in a meeting this afternoon. So we believe he's listening to the presentation en route. And I just wanted to express his thanks to everyone who put this together and to those who are attending this event. Health equity is a timely initiative, and we think the participants in this particular event will have much to gain and to benefit from taking part in this, what you're about to hear over the next 90 minutes. So thank you all on our executive director's behalf, our commissioners, Dr. Brzezinski, who is one of the presenters today, and we look forward to this event getting underway. So with that, I'll turn it back over to Anani.
Thank you so much, Dr. Sharp. Next, I would like to invite Princess Collins from the HSCRC to share a few words about HSCRC's health equity initiatives.
Yes, good evening, everyone, or good afternoon. I am Princess Collins, the Chief of Quality Initiatives at the Health Services Cost Review Commission, also known as the HSCRC. Next slide, please. So just in case you aren't familiar with the HSCRC, we are also an independent state agency responsible for regulating the quality and cost of hospital services to ensure that all Marylanders have access to high-value healthcare. The HSCRC establishes rates for all hospital services and adjusts their budgets based on the quality of care that they provide to their patients. Next slide, please. So one of the programs used to assess the quality of care patients receive is the Readmission Reduction Incentive Program, which financially incentivizes hospitals to reduce readmissions. This program includes a within hospital disparities measure that includes race, Medicaid status, and area deprivation index, which is a measure of neighborhood disadvantage. The combination of these factors is what we call the Patient Adversity Index. And the disparity portion of this program is reward only and rewards hospitals for reducing their disparity gap between those who have high patient adversity and those who have low patient adversity based on our metric. Next slide, please. So as stated before, the Patient Adversity Index is a combination of one's race, Medicaid status, and area deprivation index. We consider this to be a within hospital disparity measure because some hospitals, as we know, have a higher population, a higher percentage of patients experiencing patient adversity. And we don't want to favor those hospitals who do not. So we look within a hospital to ensure that all patients that they care for are receiving the care necessary to avoid a readmission. Each year, we estimate the association between social exposures and readmission risk in 2018 and the current year. And this allows us to look back to 2018 to see if there has been an increase or reduction in the disparity gap. So next slide, please. So here's a graph we like to use to explain how this measure works. So patient adversity is on the x-axis and readmission is on the y-axis. So we see that as patient adversity increases, percent readmission increases. But the goal of this program, however, is to flatten this line so that as the percent readmission, is similar across all levels of patient adversity. So next slide, please. While we're excited to have the only statewide program in the nation with an incentive for reducing disparities in all payer readmission rates, we understand that this is only the beginning for addressing health disparities in our hospitals. So here I have listed some next steps, and we will continue to incentivize disparity reductions in readmissions. We have also began the development of additional health equity measures, as a few of our programs also show disparities in race, Medicaid status, and ADI. So we plan to take this patient adversity measure and apply it to other measures such as timely follow-up and avoidable admissions. Next, CMS has developed 3 structural health equity measures, which we are interested in using within our quality programs to understand on a basic level if and how hospitals are advancing health equity. Also, with gender and sexual minorities being declared a health disparity population, we'll be hosting a sexual orientation and gender identity work group, which will make recommendations on how to improve the collection of SOGI data within our hospitals. Because as we know, improved data will allow for the surveillance, delivery, and evaluation of high quality patient-centered care, and in this case, regardless of one's sexual orientation and gender identity. And next, also, we will continue to work with our partners here at the Maryland Healthcare Commission to further analyze disparities in one of our metrics, which is known as HCAHPS, or it is a survey of patient experience. We have discovered that there are disparities within these measures, so it is our goal to eventually incentivize reductions in these disparities. So lastly, the HSCRC is committed to advancing health equity, and will continue to use our regulatory authority to improve the care provided to Marylanders. If you have any questions or comments, please feel free to reach out to me at princess.collins@maryland.gov. Thank you for your time.
Thank you so very much, Princess. So in the next few slides, I will spotlight a few key MHCC initiatives around health equity. In March 2022, the MHCC convened a health equity practice roundtable with representatives from advanced care delivery practices to identify challenges and opportunities for practices seeking to address key health equity concerns in their communities. The goal of the roundtable was to advance health equity in ambulatory practices statewide through the development of practice resources. Today's symposium is one of the practice resources informed by the roundtable. You'll hear more about this initiative from Dr. Zapp, and more information about the roundtable is also available at this link. Another practice resource to advance health equity in ambulatory practices is the Advance in Practice Transformation Program. The grant program began in 2021, and the grant objectives include preparing practices to deliver efficient, high-quality care while improving health equity and outcomes, laying the foundation for practices to provide team-based, patient-centered care and efficient use of health information technology, and supporting total cost of care model goals by readying practices to participate in value-based care models. MedCai Care Transformation Organization, or CTO, was competitively selected as the grantee to complete transformation activities and work collaboratively with practices to implement workflows reflective of the unique processes at each practice. At this time, I would like to invite Mr. Gene Ransom from MedCai CTO to give a brief overview of the progress.
Thank you so much, Anene. And actually, I'm going to start with thank you. Anene and Melanie are our principal contacts at the Maryland Healthcare Commission, and they are wonderful and great to work with. And I'd also like to thank David Sharp and Ben Steffen for their leadership. This transformation program is a really important way for physicians and physicians who see disparate communities to get involved in value-based care. And it's also a really important part of our total cost of care model, because we really want every practice in Maryland, not just the ones who work for the large institutions or large entities, participating in value-based care and thinking about changing their practice. And this program allows folks to do that. The program is currently supporting over 40 practices, and literally hundreds of practitioners are taking advantage of these advanced payment education seminars and readiness assessments that are being done by the MedCai CTO in conjunction with the guidance and help of the Maryland Healthcare Commission. Excitingly, some of the practices that have been in the program have been accepted into value-based programs, like the Maryland Physician Program and DPCP, and like EQUIP, the Episode Quality Improvement Program. We do, thanks to the Maryland Healthcare Commission, have openings for additional practices. We would love help identifying practices that want to transform into value-based care and think about doing things differently. If you have an idea of somebody who could use that help getting from where they are now, where they're really focused on value-based payment or the old ways of medicine, and into transforming their practice into an advanced type model where you consider value and outcomes, we would love to have them take advantage of this great grant opportunity. You can contact either the MedCai CTO or the Maryland Healthcare Commission directly, and maybe I'll have Colleen put the information, the contact information in chat. I can't thank enough the Maryland Healthcare Commission and the state of Maryland for being forward thinking and helping these practices align with our total cost of care agreement and align with this idea of changing the way healthcare goes. During the 25 plus years I've worked for MedCai, I've met a lot of physicians, and physicians really go to medical school to take care of patients. And this program is hopefully going to change the way that they get to see patients and move them away from a model where they're really on a treadmill, seeing one person after another person, and going to one where the focus is really the patient as a whole, which is why I think a lot of docs went to med school in the very beginning. And I'm very excited about this program, not just because it aligns with the total cost of care agreement, with the waiver, with the goals of advancing practice, but also because it aligns with the goals of what I believe to be many of the doctors and why they went to medical school. Thank you so much for giving me a few minutes to talk about this exciting program. And again, thanks to the Maryland Healthcare Commission, we have a couple extra slots opened up. And if you know practices that want to take advantage of transformation, please reach out to us as soon as possible. Thank you, Anene.
Thank you, Jane. I would now like to turn over the presentation to Dr. Zapp.
Thank you, and great comments. Hi, everybody. I'm Dr. Patricia Zapp, but please call me Pat. Welcome to our discussion today, Affirming Encounters, Promoting Health Equity in the Exam Room, Practical Tips for Today's Busy Clinician. We'll spend a little time on introductions and learning objectives, and then we're going to go right into the panel discussion of our case because that's the meat of today's work. And you might feel tempted to take notes. I would caution you just to engage in the discussion. We, at the end of the lecture, will have practical tips as well as some resources on slides, and those slides will be available to you after the presentation. So let's go to those introductions. I'd like you to meet my panelists. We have Dr. Ken Baczynski, who is founder of Wellspring Family Medicine in Oakland, Maryland. We have Dr. Sarah Johnson Conway, who is Chief Medical Officer of the Johns Hopkins Clinical Alliance. Ms. Angelica Newsom is a licensed clinical social worker practicing in Maryland. And Dr. Doug Spotts is Vice President and Chief Health Officer of Meredith Health. It's important to talk a little bit about why we did today's discussion a little bit differently. And I want to give credit to the designers of today's discussion. That was that health equity practice roundtable that you heard us talking about. This was a group of about a dozen physicians and leaders from across the state. We met 4 times over the course of a year, and we discussed data, we shared resources and strategies about how to help Maryland's practices address health disparities. The roundtable gave us recommendations that we really took to heart. They said, look, if you're going to have a symposium or you're going to have a learning opportunity, you better offer practical advice, things practices can do now. You don't want to add more work to these busy clinicians. They already feel overwhelmed. You want to point out the benefits of addressing health equity at the individual, family level, the community level, but also the practitioner level. You want to outline how best to use resources already available and not to reinvent the wheel. You want to describe relatable remedies that people can start today. You want to use the power of story to get your point across. And overall, emphasize patient individuality, agency, and empowerment. In the next 90 minutes, or maybe it's more like 75 minutes, we hope to influence the way you think about health equity in your practice and especially in your exam room. We will also suggest practical approaches that address health disparities in your practice, in every practice. Our learning objectives are 3. We want to recognize adverse social determinants of health that commonly present barriers to our patients' health. We want to use strengths-based approaches to empower individuals so that we're leveraging their problem-solving skills. And finally, we want to expand awareness and engagement of local community resources already available that will promote health equity. Another important objective is to increase your job satisfaction. Well, how's that? It turns out there's strong evidence that the health disparities we encounter in our practices add to our sense of burnout, especially when we feel powerless to address them. The Physicians Foundation did a survey just last year of all physicians in the country of all stripes. Here's what they found. 99% agree that health outcomes of their patients are affected by social determinants of health. 87% want to help address their patients' social determinants of health. Yet 61% feel they have no time or ability. And 83% believe that trying to address patients' social determinants of health contributes to burnout. So 99% of physicians know that health disparities are present in their practice. We don't need to conduct patient surveys or administer screening tools to detect health disparities. The disparities are there in plain sight in our exam rooms. We know that adverse social determinants of health create disparities in health outcomes, which lead to higher burden of disease and lower life expectancy for some of our patients. This cycle is self-reinforcing and has generational consequences affecting our patients' children and grandchildren. If only we could reach upstream and address the adverse social determinants of health, we might break the cycle. But how do we do that when, as Jean said, we were trained to treat medical problems? It's frustrating. We want to support practices in addressing health disparities. So that's what our focus is today. We are going to take the roundtable's advice and use the power of story, one that's going to sound familiar, to offer new perspectives to the practicing clinician. It's Friday afternoon at Sunnyside Primary Care. Dr. Evans has been covering the practice all week for Dr. Smith, who is on vacation. It's been a hectic week, and Dr. Evans and her staff of 3 people are exhausted. Dr. Evans' medical assistant, Gloria, knocks and leans on her office door to let her know that patient Mary is ready in exam room 3. Dr. Evans glances at her watch and looks at Gloria. I know, she's late, says Gloria. She should have been here 30 minutes ago, but she's been no-showing for the last 3 visits, and she's way overdue to see us. Gloria continues, oh, and I see she has diabetes. So I went ahead and checked a fingerstick A1C. It's 11.1, up from 9.8 6 months ago. I guess we have our work cut out for us. Gloria turns and walks back to her desk. Dr. Evans sighs and opens Mary's medical record on her computer. She sees that Mary is a patient of Dr. Smith. She silently reads the problem list: diabetes type 2, hypertension, tobacco abuse, obesity, non-compliance. The word non-compliance is typed in capital letters. She sees 10 medications listed, 5 for diabetes alone. She takes a sip of coffee, stands up, and walks down the hall to exam room 3, laptop in hand. So we have a patient who's been missing appointments, and her diabetes is way out of control despite being prescribed 5 medications to control that condition alone. So let's pick on our panel for a minute. Angelica, talk with us a minute about non-compliance. What is your reaction when you see or hear that word? And how might we think and act differently about individuals who don't or can't follow our medical advice?
For me, non-compliance is like a bad word. It is a barrier to creating those relationships and maintaining those relationships with our patients. So it's a label that follows someone throughout their medical chart. And so every time someone is interacting with this patient, they're met with bias because they've got that non-compliant word in their head, and they're thinking when they see this patient, what does it matter? What am I going to do? They're non-compliant. So it's really important that we come from a strength-based perspective and think about, what is this patient really good at? And is that something that I can use to help them reach their health goal and overcome this barrier? Remaining curious and asking those questions, having a conversation. The patient is the expert in themselves, so they're going to reveal to you something that you can use to really get them to move towards change. And you can use those things when you're doing motivational interviewing. So I think that's what's most helpful.
Wow, thanks. Appreciate that. Let's go back to our story. Dr. Evans knocks on the door and enters exam room 3. There she sees Mary, an exhausted looking middle-aged woman in rumpled clothes. Surprisingly, there's also a toddler in the room. The toddler looks happy and healthy. Oh, hello, Dr. Evans says, barely covering her surprise at seeing a child with Mary. Who are you? Mary growls. I'm Dr. Evans, covering for Dr. Smith while she's away, Dr. Evans replies with a smile. Oh, okay, hi. And silent. So who's this lovely little one? My granddaughter, Nicole. She's adorable. Thanks. Dr. Evans, feeling awkward, pivots the conversation to medical matters. She examines the medication bottles Mary has left on the exam table. She notices the dates on those bottles are old, and that the bottles themselves are mostly full. I see you brought in your medications. Thanks for doing that. It looks like you're on quite a few. I would find that difficult to manage. How do you remember to take them? So as a clinician, and I might ask even the audience, we've all been here. What's your reaction when it becomes obvious to you that a patient is not following the prescribed medication regimen at all? I mean, you're frustrated, right? Worried, angry, furious, you're feeling helpless, you want to give up. Let me ask Ken. Ken, what's your approach to finding and addressing the obstacles to treatment adherence, whether that's medication or any other part of the treatment plan?
Yeah, thanks. Looking at situations like this, which are numerous in healthcare, I really feel that trying to engage that part of the intellectual curiosity part of my brain helps me, mute those biases, those prejudices that you may have when you see something like non-compliance written on the chart. There's a reason why things are happening. And most often for most patients, it's internally logical and consistent why they're not doing what to us is the obvious right thing to do. So to me, I think in these circumstances, eliciting from the patient their perspective, understanding why, the why behind it. It's the same thing like when you see someone walk into your exam room, they're ill, they're febrile, you get labs, they've bumped a white count. You don't get offended because they got sick, you get curious as to what's going on and what's the cause. And I think addressing these social determinants of health, it's the same thing. Some intellectual curiosity will help us as clinicians engage that analytical side of our brain and help mute the emotional or bias side. Certainly sympathy and empathy to someone's circumstance is valuable, but necessary as a caregiver to try to develop rapport and trust. But to me, in this circumstance, it's the why. It reminds me of, in our community, we have a lot of people who are disinclined to receive vaccines. And the most effective intervention I've had has been listening and understanding their perspective, and then offering some reasonable suggestions to the benefits of changing their perspective or changing their behavior. And I've had some limited success with that. And, I think in these circumstances, any step towards improved health is a victory. It's sort of the micro victories that we're looking for, not the long-term victories that you can, hope to affect in a 15-minute exam visit.
Thanks, Ken. Those discussions with between practitioner and patient are when we flatten the hierarchy, you really can elicit good information. Let's go back to our story. I think some of these pills make me feel sick, Mary offers. Oh, let me know which ones and how they make you feel. Instead of naming medication names, Mary points to some of the pills. Dr. Evans begins to suspect Mary has some literacy issues. Okay, I see you've pointed to a pill we call metformin. How does that make you feel? It gives me diarrhea. Oh, I see. Well, that happens when you don't take it regularly. If you take it every day, eventually the diarrhea goes away. In fact, if you took your medication every day, I'm pretty sure your sugar would be under better control and that you wouldn't have to take all these other medications. Uh-oh. Mary's face becomes red and tearful. She explodes. Look, doctor, you sound just like that other doctor. All you do is tell me what I'm doing wrong. Do you have any idea what a day is like for me? Do you see this little girl? Do you know that she is with me because her mother is in prison? Do you know that I had to take 3 buses to get here and your front desk was snippy when I came in late? Do you know what it's like to lose a job because you have to miss work to take care of a child? I am sick of people telling me I need to do a better job of taking care of myself when I'm doing all I can to keep my family fed and safe. Who's patting me on the back for that, huh? I know I'm not that smart, but I know me. I know what medicine makes me feel sick. I know how to take care of myself. Mary grabs a stroller and starts to leave the room. So, oh boy, Ken? What's going on here, and what should Dr. Evans do next to show Mary that she's her ally?
Yeah, I think reframing your perspective as a clinician is essential in this encounter. You know, understanding that, you know, if I was in that circumstance, would I have made it to medical school? Would I have made it to college? Would I be optimizing my diabetic management? No, we wouldn't. But somehow this lady has been able to, Mary's been able to make it to the office, care for her child, for her grandchild, and she knows what to do to survive. And a number on a chart called an A1C doesn't really translate into day-to-day survival. And I think learning and hearing and acknowledging that she's an expert in her, that she knows herself, and she knows what she can and can't do. I think, you know, again, looking at this from, you know, a calm, analytical perspective is helpful. It reminds me of when you're in a code. You know, I do hospital medicine and we get code training, and you know, if everyone runs around panicking when someone is arresting, doesn't help the patient. And I think reacting emotionally and meeting ire with ire will be ineffective here. So listening, hearing, understanding her perspective, and then thinking, how can you relate the health outcome we're pursuing to her day-to-day life? And I think that's when people get a lot of buy-in. I know in my practice, I've seen a lot of patients who say, well, I don't care. I don't mind if I die. I'll just, you know, I don't need to take care of myself. I'm ready with dying. And I said, well, are you ready to have a stroke and live in a nursing home for a number of years? Suddenly it becomes more relevant. And, you know, I think being direct with facts in a compassionate, understanding manner can really bridge these barriers and you know, the offense that people have when we focus on numbers and data and health outcomes, which don't really translate into their day-to-day life. Whether their hypertension is controlled or uncontrolled, they feel the same today and tomorrow. Now, 10 years down the road, they may have marked cardiovascular outcomes. I think it's our job as trained clinicians to help people make that connection between healthcare decisions they make today and the healthy, active lives they want to live today, tomorrow, and down the road.
Thank you. And, you know, as we've been listening to Mary's story, watching her, hearing her, Sarah, what social determinants of health have we already identified in Mary's case that are adversely affecting her health?
Yeah, great question. And I think there's actually quite a few that have come up already in the context of just this short interaction with Mary. I like how Ken framed things earlier in terms of the logic of the patient. And I think it's really important that we understand the obstacles and challenges that the patients are facing outside of that exam room, things that might make it, that might take precedence over her taking her metformin and on any given day. So I think that's a really important framework. So here, this is the one way of breaking down social determinants of health to try to understand what are some of those obstacles that your patients may be facing in any given encounter or in their life sort of before they come to that encounter. The first is really economic stability, and this is a critical one. We get signs here that she is struggling in some way with poverty. She's lost her job. She now has childcare expenses, and we know that poverty can both impact the likelihood of you developing clinical risk factors and also the ability or opportunity for you to address any of those health issues that you have. So that I think is an important one for her. In terms of education, access, and quality, what we hear from her is a concern about the stigma. She makes a comment on her self-evaluation of her intelligence. She makes a comment about her, either the mother of the child that she's caring for being in prison. There's also reference to her healthcare literacy. She doesn't really understand her medications. She's pointing to her medications, which speaks to the fact that she may have some barriers to understanding the complex regimen that she's even been assigned. I think when it comes to the neighborhood and the built environment around her, we hear about her transportation challenges, the fact that there isn't easy access to a healthcare center for her, that she has to take 3 separate buses to get to an appointment and then to arrive in a 15-minute interval. You can imagine makes it really challenging and has probably led to her missing a number of those appointments prior to this one. And then from a social and community context, again, she has childcare duties now and is caring for her grandchild and working in a community that, again, may link back to some of those stigma issues that she had. So even from this brief, 3 to 4 minute encounter, you can see that she is facing a number of personal and lifestyle hurdles that she's bringing to this exam room. And so this encounter is not really just about that one question of where her blood sugar is or where her blood pressure is, but really about her as a holistic human who's facing all of these challenges and bringing that to the clinician to help her think about her healthcare specifically in that broader context.
Thanks, Sarah. Let's get back to the story. Wow, says Dr. Evans softly. You have so much on your plate. Mary sighs and sits back down. Look, I'm sorry I blew up at you. Don't apologize. I'm so glad you let me know what's going on. You're right. You do know how to take care of yourself. It sounds like the medications are giving you some trouble. If we could do anything with these medications, what would that be? I don't know. There's so many. And I have to remember to take them different times of the day. I think I could manage taking pills once a day. What if we could get it down to 3 pills you take once a day, every day? Would that help? Yeah, it would. And what if I gave you a pill box? One of those Monday, Tuesday, Wednesday things, and you could put 1 pill of each of the medications in the box every day, so it would be easier to remember to take them. By the way, I do the same thing for myself, and my husband does too. Mary looks doubtful. Well, what time of day do I need to take them? What time of day works for you? Mary laughs. Well, I guess first thing in the morning when this kiddo wakes up. That works. I'll be right back. Dr. Evans leaves exam room 3 and heads down the hall to grab a pill box, and more importantly, to grab a moment to think. Mary's social problems are overwhelming. Doug, I want you to put yourself in Dr. Evans' shoes for a minute. Where do her responsibilities begin and end to help Mary's social problems? You know, she's a doctor. So how can she be helpful to Mary without despairing she can't do more?
Well, our fellow colleague and fellow panelist Ken typed in the chat a wonderful segue to that very issue. And I think particularly for the physicians today, you know, it's so important to remember we can't, nor can we be expected to solve everything. But we're still the physician, we're still the provider in the moment. And I think, you know, taking that pause and stepping back from being overwhelmed and saying, well, what can we do in the moment? That simple solution of the pill box to help tackle one of the problems. And then saying, what can we do to make the connections for some of the longer term problems? And I think that that's the challenge for all of us in clinical practice. But I think it's really important to remember that team-based care and relationship building are superpowers of all of us in primary care. And that's not just the physicians, that's all the members of our teams. And so, you know, do what makes sense in the moment, but work on those longer term solutions with your team members and be able to step back and say, I don't have the immediate answer right now for this issue, but I'm going to work on it and I'm going to get back to you. If we had a patient in front of us with cancer, we wouldn't manage that alone ourselves in primary care. We would refer, but I don't mean refer like check the box in the EHR refer. I mean, we know those relationships within our teams and in the community. Let's make that referral, but then follow through and, you know, really look at, you know, what are the resources that are helping us to close that loop and verifying that with the patient and knowing that it's really a journey and that single step you know, begins the journey, but that we really are in a good position to help continue it.
Thank you. And now let's get back to our story and find out what's going on. Dr. Evans asked her medical assistant, Gloria, for a pill box. As Gloria hands it to her, she asks, how's it going in there? I thought I heard shouting. Yeah, she's pretty upset. She's got a lot on her plate. That's why her diabetes is so out of control. I'm just trying to keep her from storming out. I'll knock on the door in a few minutes and see if I can help. Thanks, Gloria. Here we go, says Dr. Evans as she re-enters exam room 3. I'm going to pick 3 pills for you to take once a day, every day in the morning. She quickly fills the pill box and hands it to Mary. Now, don't throw away the other medicines. We might need them. I'm not sure yet, but I'll be able to tell once you've been taking these 3 on a regular basis. Make sense? Yeah, I guess, Mary shrugs. So can you come see me in a week so we can start working on checking your blood sugar? I'd also like to get some blood work done today, if that's okay. They both turn to the door as they hear a knock, and Gloria, the medical assistant, enters. Mary looks down quietly. I'm not sure how I'll get here. I told you about the 3 buses. Gloria joins in. I think your insurance company might arrange your transportation to medical appointments. Can I check on that and get back to you? Well, I guess, but I'm not sure I'll have phone service in the next few days. I've run out of money to pay the bill. How can you call me if that's the case? Dr. Evans tries hard not to get more discouraged and looks to Gloria. Do you think that heart money could cover her cell service? Gloria frowns. I'm not sure. I'll certainly check. I did hear on a webinar the other day that we can sometimes get the federal government to pay for a cell phone or low-cost cell service. I'll check my resources. In the meantime, Mary, why don't you give me an emergency contact I can use in case your service is discontinued? We'll figure it out. So we will see each other next week, right? Says Dr. Evans, achieving eye contact with Mary for the first time. Yes, we will, replies Mary. So more questions for my panel. Angelica, let's talk about Gloria. Gloria is a godsend. Her role is enormous here. She's a tremendous help. How do just ordinary practices find and empower employees like Gloria?
So I think sometimes we think, we have to have a community health worker or a social worker to be able to provide these resources. But really, Gloria is a perfect example of somebody that's from the community. She knows what's going on. She's an insider. And her role actually allows for her to have a less formal interaction with the patients, kind of getting rid of some of that white coat syndrome. So patients are going to reveal more to Gloria than they might to you right off the bat. You know, from personal experience, I had an MA that worked with me, and we had a client that needed dental services, and I had used all of my resources as a social worker. I was tapped out. And this MA said, oh, I know, she can go to my dental office up the street. Let me just call and make sure that they take the insurance, but I think they'll be good. Turns out that was one that had an opening, and it wasn't me as a social worker that provided that resource. It was the MA. So, you know, it doesn't have to be someone that we typically think of that's fulfilling this role. It can just be somebody, your front desk receptionist, that just really knows what's going on, is talking to people, and is gathering these resources in your community.
Cool, thanks. And Sarah, to that point, how do practices develop lists of go-to resources so that they and their patients can access what's already available to them in their own community?
Yeah, I think it's really important to identify, a go-to person to begin to collect those lists within the practice. And I think the theme was touched on earlier, that go-to person does not need to be the provider, that there are other members of the care team. Even if you're not in a huge practice with community health workers and others, there can be a front desk staff, an MA, it could be anyone really in the practice who is able to talk to patients and has an interest in helping to solve these. You know, I think it's particularly scary for clinicians. You don't want to ask questions that you're not prepared to answer. But I think this example helps show that, you know, even if you can't answer it right away, there are people in your practice who might be able to. So I think the first thing is to identify who that go-to person is to maintain the repository of information. There's going to be a handful of questions that you get asked over and over and over again, things like transportation, whether or not that's through the insurance company or MTA mobility or whatever else resource might make the most sense in your community. And then they can maintain a list of those resources and those that are really good at getting back and those that maybe aren't as good. And so you can get more facile over time and referring patients to those. And then I think when there's new questions that are asked that you don't have the answer to, there's opportunities to use your local health department or findhelp.org or something else that can identify a specific resource that's worth trying to face whatever specific challenge your patient's having. And then again, having that lead person keep track of those resources as you try them out and hear from patients if they're working.
Thank you, Sarah. And Doug, in the story is mentioned heart money. What is heart money?
Sure, I'll stay at a high level of overview and just note that if you would like to learn more about heart, we will have that link to the Maryland Primary Care Program and the Heart Payment Playbook on a slide later in the presentation under resources. So you don't have to feverishly take notes here. HEART stands for Health Equity Advancement, Resource, and Transformation. HEART is an additional funding feature for practices participating in the Maryland Primary Care Program, MDPCP, and the goal of HEART funding is to address the complex needs of under-resourced Medicare beneficiaries. So by providing this extra layer of support, patients improve their social conditions in the short term and their clinical outcomes in the long term.
Thank you for that. And let's get back to our story because it's not over yet. A week passes. Mary returns to Sunnyside Primary Care on the appointed day. Her granddaughter is with her again. You're here, yay! Dr. Evans says brightly as she enters the exam room. Yeah, Mary grins and looks at the floor. So how did the week go? How'd you do with the pill box? How do you feel? I did okay. I just missed one day, and you're right, the diarrhea came back, but it's getting better. Mary puts the nearly empty pill box on the table near the sink. That's great. We'll help you refill that pill box yourself today. I've got some things on my agenda today. I was going to go over your blood work results with you and discuss some options for you to check your sugar at home. First, though, what did you want to talk about today? Well, Mary hesitates. I was wondering about two things. I'm wondering if Gloria can tell me how to get food stamps, and I want to quit smoking because I can't afford it anymore. Can you help me with that? Dr. Evans' eyebrows shoot up in pleasant surprise. Yes, I can. She pauses for a moment, then says with a smile, gosh, you've really got this, don't you? Fast forward. It's the end of the workday at Sunnyside Primary Care. Dr. Smith, who is back from vacation, sits down in Dr. Evans' office and sighs. Well, I'm back to the old grindstone. Oh, I see you saw Mary, my non-compliant diabetic. She rolls her eyes. Boy, she is a stone in my shoe. Welcome back, says Dr. Evans. She pauses, then smiles. By the way, about Mary, I really like her. I don't think she's non-compliant. When you've rested, let's discuss her case, okay? And that's the end of our story, but not the end of our discussion. We're going to move on now to what we promised you, which is some slides about practical tips and resources. And each of our panelists owns one of these. Practical tip number one goes to Angelica.
You're on mute, Angelica.
Sorry about that. So tip number one is to think about the patient being the team captain. I actually say this to patients so that they know that what they're saying is valued and that they're the expert and that I'm going to work with them rather than fighting any resistance. So prioritizing what matters to them. And then also just realizing that patients are allowed to make bad decisions. We're human. And so those are the opportunities and moments that we can use motivational interviewing to see if we can move forward and figure out, you know, how we're going to overcome this barrier with this patient for what's going to work for them. And so not trying to be perfect, you know, simplifying their medication regimens. For example, I've had patients that I've suggested that they pair their medications with their telenovela or their story so that they know that's a signal, it's a part of their ritual already. And so we're working our plans with their plans, and you know, there's more buy-in and there's going to be more success that way.
Thanks, Angelica. And I know practitioners sometimes struggle with that because they get balled up in the whole standard of care, but just recognizing that the traditional approach has not and will not work for this person can be liberating. And go ahead and suspend that agenda of perfection for now and just break things up into smaller steps. Let's go on to practical tip number two, which is Doug. And
Yeah,
go ahead
wonderful.
and load all the tips. That's fine. Thanks.
Yeah, great. Yeah, so definitely honor individual skills, wisdom, and experiences in keeping themselves safe, and stay curious, ask about their plan, stay focused on their strengths and their proposed solutions. And remember, you know, maybe even at the top of that, don't panic. You don't have to, and you can't, as we said before, solve all of their problems alone. You know, we just heard a powerful story, and we collect powerful stories every day as clinicians. And I think it's so important to honor and recognize the power of the story and really taking a good history, pausing even in the midst of the rush of busy schedules, sit down, face the patient, not the computer, really listen first. And I think, you know, involve them in their care, use teach back, you know, make sure that they are exhibiting an understanding of what you've just talked with them, and does it make sense to them? as Angelica said, we started a whole project here at Meritus just to capture with our patients at every encounter what matters the most to them, because it just totally frames up the conversation in ways that maybe we don't always perceive as clinicians, but opens them up and invites them into their care. And again, applying, our intellectual curiosity to their curiosity about their care, and developing the plans together can be so tremendously powerful. And I'll finally say, a real life Mary for me that I'll never forget in clinical practice was Lois. And Lois always was immaculately dressed, always controlled her diabetes type 2 extremely well. And we knew in the practice that Lois's husband had died. And when she returned, she had a A1C that had really jumped. And she, you could jump and make the conclusion in your mind, well, she's been grieving, she lost her husband. But when we asked her, the numbers have changed, what happened? She just burst into tears, and she admitted that she was taking her medicines, but that she was not financially stable to be able to afford and buy groceries and healthy foods, and that she was eating saltine crackers and jelly on those crackers. And that's why the number changed. And so if you don't ask the question, if you don't involve the patient in the care, you can't sort of get to the resolution. And we were able to provide her resources of getting healthy and nutritious meals through the community, and helped to turn that around. So that's just a powerful example from real life practice for me.
Thank you for sharing that, Doug. And certainly, the point about not panicking is we encounter individuals who are in tremendously complex situations that would maybe put our hair on fire. But when we react with panic, they sort of say, well, shoot, this lady's really freaking out. I must really be in trouble. Then all their problem solving skills go out the window. And I was taught that. I didn't learn that in medical school. And, with Mary, we aren't going to tell her not to be angry, and we're not going to teach her to read, get her a car, get her a new job, and get her daughter out of prison today. But we are going to be her doctor and her partner, as you have said, and her ally, really, and just do what makes sense in this moment to support her so that we don't get burnt out and worried. Practical tip number 3 goes to Sarah.
So first, I'll start by saying I love that story, and the power of the story, I think, is really valuable here. And I think a lot of this, part of not being afraid or not being scared to ask these questions, is to realize that the skills that it takes to address some of these social determinants are very similar to the skills and approach we take to addressing any other clinical problem that our patients face, right? So we can't think of it as this separate thing over here that we have to deal with now, but rather it is a part of the overall clinical care model that we are taking on as clinicians on a day-to-day basis. And similar to how we might have a patient with cancer or something that is outside of our clinical scope, and we refer to specialists, we have to have a similar framework for that, for management of some of these social determinants that our patients are facing as well. And so it's really about building that bank of specialists that you can refer to both within your office and outside of your office in order to be skilled, just like you do to figure out what's the best community cardiologist that you can get your patient into quickly. It's really the same concept and set of skills here. So identifying that internal expert who you can rely on, or experts within your practice. Sorry? Yep. The internal expert or experts that you can rely on in your practice to refer to, and then sort of gathering that list of community resources that you find to be particularly helpful. And that is going to be different based on where you are, where you live, and the local resources that are around you. And this is where you can look to your local hospital, you can look to the patient's insurance company, you can look to health departments, you can look to findhelp.org, which used to be called Aunt Bertha and has now been rebranded, and they really will help to give you resources. The other things that, we heard from a medical society earlier, we heard about the heart funding, and CRISP also has some resources. So there's a lot of different places that you can go to ask for help. So you are not alone in this effort. It's just a function of learning how best to set up your referral network, just as you would for any other clinical problem your patients face.
Thanks, Sarah. And later in the presentation, we do have some slides on resources. So again, put your pencils down, guys. You don't have to take notes. Ken, can you take us home with practical tip number 4?
Sure thing. Appreciate this. Yeah, I think as I sit on the commission, as I've worked with the MDPCP advisory group, what we bring as primary care providers, and that's my lens, that's what I am, primary care. The real asset we bring is a trusting relationship with patients. And when we build that trust, that's how we can move the needle on outcomes for patients to find their own best self, their own healthiest self. And hopefully also for us to meet the quality metrics which we're beholden to. It is a bit of a struggle. We are sort of a middle management, we're responsible for clinical outcomes, but we don't have the ultimate say because we're not the patient. And society has chosen to insulate patients from a lot of the financial consequences, direct financial expenses of adverse health outcomes. So it's very hard to find real motivation. But as primary care providers, that's our superpower, as one of the other panelists says. We develop trust, we get to know patients, we try to understand their perspectives and try to reframe our thinking to their perspectives as to how we can then achieve optimal health outcomes for our patients. And I mentioned this to Pat before, I have the opportunity to coach on a mountain bike team, and one of the phrases we use is micro victories. It's not winning every race. When there's hundreds of racers, you're not going to win a race. But maybe there's a new skill you develop today. Maybe there's a new success on an obstacle. And that's what it's like with our patients. It's not optimal diabetic control for a decade that we're trying to document today to next visit. It's one step forward, just like we demonstrated with Mary. Consistently taking medications, returning for a follow-up visit, definite victories. And the shared decision making, really empowering patients to make decisions that are congruent with their worldview and their social circumstances. Meanwhile, using the resources that we have to try to mitigate the adverse effects of their social circumstances. I am thankful to be in Maryland. I don't often say that, but as a primary care provider, I very much am, because there's been historic systemic bias in how we fund primary care. We have a few safety net providers that we put a lot of resources at, and we fail to invest in the tightrope. Many of us go into primary care, as the data shows, because we want to impact people's lives and health and deal with these social adverse social determinants of health, but we're not resourced. But in Maryland, we take big step forward with the Maryland Primary Care Program, with HART funding. I mean, there is few people in the country, few states in the country that have anything similar to this. So I am exceedingly thankful for the work that Maryland has done for this, to really try to address it and to try to shift the programmatic and funding inequities that lead to a lack of resources in many communities, but to spread those resources through a lot of practices across the state. I think I'm hopeful, I'm enthusiastic that we can really move the needle. And I hope that our patients would feel that in the exam room, in the community, we run into them as well. So I just really appreciate the opportunity to be part of this in our state.
Thank you, Ken. And thank you to all the panelists. I am going to turn it back now to Anene so she can go over those resource slides.
Thank you very much, Dr. Zapp, and thank you, Dr. Bazinski, for sharing that practical tip. So next, I would like to highlight some statewide resources that can help you address health equity challenges, and we've touched on some of these during the presentation. CRISP, the Chesapeake Regional Information System for our patients, currently has a social determinants of health suite of tools that improve social determinants of health data sharing between members of a care team. This includes social needs assessments, referrals and status, Z codes, a resource directory, and the ability to make referrals to specific community-based organizations. The resource directory pulls in CRISP's own resources, as well as 211's resource data to search for resources for patients. Another resource, findhelp.org, which Dr. Conway talked about, offers a free suite of tools to streamline care management and find social services. Unitus.com provides a platform to connect patients with community-based resources and facilitates referrals to social care providers. The Maryland Primary Care Program, or MDPCP, is a voluntary program for qualifying Maryland primary care providers that provides funding and support for the delivery of advanced primary care. The program supports healthcare transformation using funds such as the HART payment and enables primary care providers to have an increased role in preventing and managing chronic disease and reducing unnecessary hospital utilization. The HART payment playbook provides guidance to MDPCP practices related to understanding area deprivation index, or ADI, and the HART payment. It helps determine the most effective and appropriate use of HART funds, and also with understanding necessary tracking and reporting of HART payment usage. So Dr. Zapp, it looks like we have some time for questions. At this time, if you have a question, if you can raise your hand or include your question in the chat, we'll be happy to take this.
There is a question for Angelica. I think this is a good one for you. So Angelica, in this story, Mary was very forthright. She just kind of let it all hang out, you know, with her anger, which was great. So we knew what was going on in her life. But for many patients we encounter in our exam rooms, it's just sort of sometimes a one-way conversation. And perhaps we even unintentionally shame some of our patients. They're not very forthcoming to say, hey, you know, my husband died and I don't have enough money to buy food, or that I have this problem with addiction, or I got to get my son out of jail. How do we, one-on-one in the exam room, make it safe and comfortable to have these discussions? What kind of conversation, what kind of words do we use?
So we're going to be non-judgmental, of course. That's why words, going back to the first thing of like not using non-compliant, is so important, because it can come off as a critique. So we're going to use open-ended questions that give the patient the space to tell us what's going on. I know that some offices are using screening tools like those social determinants of health screening tools as a part of the intake when you first come into the office. And so that could be your opening. You know, I'd like to take some time to review some of your answers on your screening. You know, can you tell me a little bit more about what's going on with food in the house? And so, you know, you're opening the door in a gentle way. You gave them a chance to identify this without directly asking the question, which can sometimes be off-putting. And of course, we're going to make sure that we ask patients before sharing information or advice. You know, again, a lot of patients see doctors, you know, in this high esteem, as you are the expert, but sometimes it can create a challenge with communication. So asking, you know, do you mind if I share some information with you? For example, with Ken and some of his patients with vaccines. Just automatically saying, you know, oh, your idea about vaccines is totally wrong. Asking, can I share some information with you? Can I point you to the CDC's website? You know, read it, and, you know, we can discuss. Let me know what you think. If you have questions or concerns, I'm here. Kind of giving people that space is really important. And I think, you know, starts to build the relationship as a team, as we're doing this together. I'm here for you. Rather than, you know, for some of our older adults, it's whatever the doctor says and there's no input from them. So, and then of course, it's already been touched on, but making sure we're not in our laptop or typing when we're asking these personal questions. If we're going to ask about this and really dive in, then we want to make sure that the patient knows this is safe. I'm paying attention to you. We're reflecting back to them the things that they have said too, so that they know that, yes, we listened and we understood what you were saying and what the problem is.
Thank you for that. Any other questions so far from the group?
We have a couple in the chat if you'd like for me to highlight them.
Sure.
So Darlene asked, finding quality care is difficult in the Baltimore area because of staffing issues. How will this be addressed? So that's unfortunately outside of the purview of this particular webinar that we're having, but I will tell you that, you know, there are different initiatives underway throughout the state to try to address this. I don't know if any of the panelists in particular would like to step in on that, but we do realize that this is a problem actually throughout the whole state.
I'd be happy to comment on this. You know, in an opposite but analogous manner, I serve in rural Western Maryland, where, you know, we're resource limited as well. And personally speaking, the MD-PCP program has preserved my practice. I have a small private practice here with several physicians and PAs and a nurse practitioner. And if it wasn't for that, it would have been very hard to keep our doors open. And I can't imagine why a primary care practice in Maryland wouldn't participate in MD-PCP if they had the opportunity. It has been tremendous. The care transformation is real, moving from the hamster wheel of seeing patients earn money to having funds for some of these care coordination, mental health services. It's a lot more satisfying, you know, being able to address the broader scope of patient needs. You know, we have uncontrolled diabetes in Maryland, not because we lack effective medications, treatment, and knowledge of how to do it. It's because we lack the ability to have patients understand and buy in and comply and engage the process of healthier living through diabetic control. So really, I mean, all this discussion, it reminds me of when mental health parity was an issue a decade or two ago, that people realized, oh, mental health issues do affect physical health issues. I mean, no one would argue that now. And I think that as medical science has advanced, our real limitations to people achieving optimal and healthy outcomes in their lives is not so much the medical knowledge and resources, it's the ability to apply those and have people engaged to using those. So, you know, MD-PCP takes a big step towards that. The heart payment does as well. So again, I'm thankful to be in Maryland to have these kind of resources.
Thank
And
you
I'll
so
just,
much.
I'll add in on the staffing challenges. I mean, I think not only is it prevalent across the state, I think it's prevalent across the country. And we're seeing, you know, this impact providers, health systems, you know, across the board, and even outside of healthcare industries as well. And so I think, you know, there's a lot of short and medium and long-term solutions here that are being deployed. And I think you know, people are trying different ways to address this. And I'm sure even at the state level, there are things in place, but a lot of what we're hearing from clinicians, staff alike, is really an increasing need and demand for flexibility in the workplace. And so, you know, are there different opportunities for, you know, partial FTE or part-time jobs or other things that allow for people to manage, you know, a changing landscape for their home lives as well, which I think has been really important. Another thing that, you know, I think is important is training and workforce development and creating a pipeline to really bolster the ranks of healthcare providers. And so I think that's another thing. And I know that there's dollars at lots of different levels to support efforts like that. And then another theme that we hear a lot is around protection of our frontline workers. I think there's been a lot more, you know, aggression in the workplace, a lot more stress in the workplace. And so making sure that there is backup and protection for folks so that when they're doing this really hard work, when they're doing this transformational work, that they feel personally safe and protected in doing that care. And so I think those are just a couple things. And I know that there's many other initiatives sort of at all levels to address it, but it is a challenge that I think we're really all facing and having to get pretty creative in order to meet the demands and needs of our patients and to give them the care that they deserve.
Thank you. Those are great points. Thank you. So the next question, I agree that addressing social determinants of health is essential to providing holistic healthcare service. However, resources are limited in addressing patients socioeconomic needs is challenging. What can we do to close the gap? And Pat, maybe I'll let you recommend one of the panelists to, this is in the chat if people want to read the actual language on it.
Sure, and this might actually be a good time to show a tool that I know Sarah and I are champions of, and that's findhelp.org.
That's a great idea, Dr.
Yeah, why don't we do that? So, and Sarah, feel free to chime in or even just take over. But, when we recommend things, I like to kind of try them out myself. So if you just type into your search engine, findhelp.org, you get this. And yeah, up on the right, it says sign up or log in, but you don't even have to do that. And it automatically loads your zip code in, which you can change. That's the blue arrow. And then the red arrow is, which I like, is a reminder about 988, which we tend to forget about. Next slide. So I pretended I was going to be in Crisfield, Maryland. So I typed in Crisfield, Maryland's zip code, and I found 2,000 programs. Now, I know. There are not 2,000 programs in Crisfield itself, but there's a lot of overlap of programs that are regional, national, et cetera. But let me point out a couple of things. So up on the top left, you don't have to search all through all those tabs. You can just, and I did in a next slide, but don't go there yet. I was wondering about cell phones, but you don't have to just go through every tab to find things. And you can also select your own language. You see across the tab, the top, food, housing, goods, transit, health, money, care, education, work, legal. So this is pretty comprehensive. And go ahead to the next slide. So I did type in cell phone for Crisfield, Maryland. And right away, I got Lifeline cell phone service, which is actually that program that works with the government locally to get people either cell service or phone or both. But across the top, again, you see personal filters, program filters, income eligibility. So I thought, well, let's say I wasn't sure I wanted Lifeline. I was just going to play around with it. And go ahead. Personal filters, if I wanted to, I don't have to. I can filter on any of these and more. Program filters, I want to call them. I want to schedule. I want to be there in person. Are they open? Are they open on weekends? Is it free or is it just reduced costs? And then income eligibility, if I wanted to filter, I could. Next slide. And, so how many family members live with you and how much do you make per month, et cetera. So I just show that because you can really filter down. Next slide is, I decided, I want to go ahead with Lifeline cell phone service. So I just punched the more info button and immediately, next slide, it gives you this wonderful thing. You can print it out or you can just leave it alone. But it gives you eligibility, available, the description, and next slide. Also languages, costs, what do you do next? What is the coverage area and what documents do I need to gather? So you can do this as a patient, you can do, your front desk person can do this, your office manager can do this, anybody. It's just really seamless. And Sarah, what did you want to add about findhelp.org? Because I think you're a fan too.
Yeah, I just like to highlight that it's self-explanatory and it's easy. And I think that oftentimes when people tell you to go to a website, it seems overwhelming, but I myself have done it and used it for patient encounters and found it to be pretty user-friendly. And so it's not something that you need tons of education or experience or training on. So I like that. And I think it's a great resource for people who are new to an area or new to a problem and just need some ideas.
So we have a question about this resource in there. Someone is asking, does this resource search engine connect with other existing Maryland funded resource directories like 211 or Network of Care? I don't know if either of you know that. I know CRISP does also connect to 211. That information is available in CRISP. Do you or Pat, Sarah, have any idea if it's connected?
believe there's significant overlap, and yeah, you can go on 211, or you can definitely go on CRISP, especially if you already have a relationship with a CRISP, and all of us do, right? Because we're using the PDMP. The reason I like this is it's sort of like, all you need to remember is findhelp.org, and you can just go into it and get what you want. These different search engines, I find, are not mutually exclusive. Like, you're going to find A, B, and C on any of them. It's just, for me, this format is just so immediate and easy.
So I'm going to highlight one other question in here that was, how do you explain heart payments to your patients without being, quote, wonky, quote? So do you want that one, Doug? Is your hand up to take?
Yeah, I just typed in the chat if we didn't get to it, because I was monitoring, monitoring it as well. This would be my suggestion. The rest of my fellow panelists can chime in, but I would suggest that, knowing about it as a tool for the awareness of your team that provides some extra resources to address social determinants of health needs. In the moment with your patient, I don't think you need to go into the wonky explanation of area deprivation index and their high risk, their HCC coding, right? That's all the stuff that we know plays into that. And there are resources in the resources section to delve into that further. But if you know that that's available and the patient qualifies for it, it's just another tool in the toolkit to provide some extra sources. So depending on your team, the size of your team, whether you're part of the MDPCP program, the CTO, I think there are other people that might be able to better address that. In the moment, I don't know that you would really have to get into the wonkiness. I hope that helps.
So thank you for that answer. I think that I've addressed all the questions that are in the chat. I would like to give a special thank you to everyone for the great support and advice today that you've given to our practices. I would invite Pat if she would like to make any closing remarks, and then go to Dr. David Sharp to make any final closing remarks.
Oh my gosh, I wasn't expecting it, but I'll be brief. I have been delighted to work with the team for over a year, really, on, what are we going to do about health equity? How are we going to provide some recommendations to the commission about how to move forward? And I will channel Ken, who said, I think we all learned a lot as we went through it. And all of the panelists today, including myself, were on that initial roundtable. And I'm incredibly grateful. Incredibly is an overused word, but I am incredibly grateful for this opportunity and for the collegiality of my panelists in working on this project together. We deliberately, intentionally kind of departed from the usual format with the story base. And we're really eager to hear what our audience has to say about that format, whether they'd like to see more of that or less of it, and what they want to hear about next. So please fill out the survey, and thank you.
And I would just follow up by opening the floor to some of the other presenters who presented today in the few minutes remaining. From the Maryland Healthcare Commission's perspective, thank you all very much. Thank you for those who took time to attend. I think this was an excellent presentation, excellent presenters, great questions from the group. Can't say enough good things about it. So I'll pause there and invite the doctors and Angelica to say a few words in closing. And I can tee up Dr. Conway first, perhaps.
First, okay, lucky me. No, I think this is it's been a wonderful opportunity to participate in both this roundtable, or the broader roundtable, and then this webinar. We hope that it's provided some valuable tools. It is, so critical to the practice of medicine today to really take on these challenges, and so a lot of it is learning together and sharing the best practices that we learn, so that we can all be better at helping our patients. So I'm really thankful for the opportunity and hope it was helpful for folks.
Thank you. Dr. Buzinski.
Sure. I have to say this roundtable, this health equity roundtable, has been so enriching for me. In a small town, 3.5 hours away from the big cities of Baltimore and Annapolis, just feel isolated and on the fringe so many times of healthcare. And the cross-pollination of the people working on this group was tremendous. Pat was excellent as a moderator and really brought out a lot of the best in the people involved. And I'm really humbled and honored that this many people would spend a Friday at lunchtime to listen to what we have to say. But I really think addressing this resonates with why a lot of us went into medicine and or into our healthcare professions, and helping people overcome these non-medical barriers, the barriers that don't get fixed with a pill or a surgery. It's really meaningful, and it really is a good antidote for the burnout, which seems so prevalent. Thank you very much.
Thank you, Dr. Jasinski. Dr. Spots.
Yeah, again, humbled and honored to be a part of this panel, a part of this work, a part of this group. It restores great joy and confidence in me personally. And I think somebody said it very early in the presentation, takes us back to our roots as physicians, as any of us in healthcare, of why we got into this profession to begin with, our calling, our purpose. It is so important, I think, coming out of this great time of disruption, to not sort of just be in despair. I think it's a great time of hope. Don't be afraid to take that one step, one bold action in your practice, in your individual service in the community, in your health system leadership. You're all leaders, and I'm a firm believer, to use an orchestral illustration, that you can lead from any chair. It's not just the first chair. And so to do this work, I would just really encourage you. You all have had great comments in the chat, and lean into it, ask the questions, use that inquisitiveness and your leadership to lead from any chair.
Wonderful. And Ms. Newsom.
Wonderful experience working with all the panelists, everyone that was on the round table. For all the providers that have shown up today, you guys are excellent advocates, just even being here and having this discussion and exchanging ideas. Excellent advocates for your patients. So I'm just really happy to see that our medical community, this is something that you all value, and it's only going to help your patients.
Indeed. Thank you so much. Melanie, back to you for closing us out, or Dr. Zapp.
Yeah, I'm gonna just turn it to Anana. She's gonna let us know what the what's gonna happen now.
Thank you very much, Melanie, and thank you to everyone for attending our symposium today. We have come to the end. You will be receiving the questionnaire, as Dr. Zapp mentioned, in an email following this event. Thank you very much. If you have questions, please feel free to reach out to us via email.
We will
Have a great.
We'll be posting this to the MHCC website. So if anyone would like to hear this or share this with colleagues, the link will go out to everyone in an email, and we encourage you to share this with others if you found it to be useful. Thank you again, everyone. Have a wonderful day.
Thank you.